about the volume you treat, so that before we go into this, we'll have some idea, so that we can share our volumes also, to just to have an idea.
Yeah,
if
yeah, of course.
with you, if you're comfortable.
You mean, sir, larynx?
No, in general, head and neck, we can have
in general. No, okay, okay.
A general rough
so
idea.
in head and neck, we take care of around 3,000 patients a year. 3,000 patients a year. Okay. So most of the patients are oral cavity, 50 to 60% maybe oral cavity. Then rest constitute the oropharynx, larynx, hypopharynx. Nasopharynx is a very small portion. Then salivary gland tumors, other are low in number.
Okay. So 3,000 is actually a huge number, because our total registration of all cancers is around 3,000 in our department actually. Yeah. So that looks very nice. So what kind of projects are running, if I can know, so that we might also plan?
Yeah. So basically, now we are collaborating with the research team also, and also the surgeons, and the new few thrusts we are ongoing is, one is the prospective evaluation of few things, because we know that the most of the data comes from the West. Okay.
Yeah, exactly.
So when we extrapolate that into Indian population, because we come across a lot of issues in replicating that. Okay.
Okay.
And other thing is that regarding the radiotherapy, if you look into the Americans, usually they prefer conventional radiotherapy. We are more towards the Europeans and mainly the British system, especially in vocal cord, in buccal mucosa disease. We prefer to give something like a high dose per fraction. So the thought process in the oral cavity is something like, so what is the real role of induction chemotherapy? Because in a patient with, and we come across a lot of waiting periods also for doing surgery, say for 3 to 4 months, 4 to 6 weeks period. So what is the role of chemotherapy? So one of the running studies is the role of TPF. If you can give something like an induction chemotherapy, like in good patients, that is studies, these are the projects running under me. One is this. So we are really looking into the role of the TPF in preserving the organ preservation. Can we reduce the extent of resection in tongue tumors? Where we can avoid flaps, like because we come across that in tongue tumors and also in gingival complex tumor, we need a big flap, then plastic surgery support. That may not be possible in community practice, especially in medical colleges or something like in the periphery. It's not possible. So dedicated head and neck surgery team with a good plastic surgery support should be there. So can we reduce the extent of surgery and avoid flaps? And also, can we preserve the mandible in certain, because most of the time when we do a resection, we may have to remove the mandible for en bloc removal of the tumor. So can we reduce the extent of resection? These are all concerns. So that's one study which is going on. So basically what we are looking is, you give 3 cycles of TPF, then you do surgery, then you give post-op radiation. If any adverse features, then you give post-op chemo radiation. That's one study which is
nice to know that big studies
because we are prospectively evaluating the toxicity, because we are using the European protocol, the TPF. So whether that is in a prospective evaluation, because although we were using that, we have not utilized in a prospective manner. So we are doing that.
All right.
Where it is really helpful. Now, another thought process which is coming up in the recurrent bar metastatic setting is based whether what is the role of something like what is the innovative things like low dose nivolumab. Okay, whether it is useful. Other concept which is coming in nasopharyngeal carcinoma, because we also come across a substantial number of patients in nasopharynx, is really an adjuvant chemotherapy has a role, because chemoradiation itself is very toxic than the number of patients who can tolerate. Although there is some data from China which is coming up in a big way that whether we can give adjuvant capecitabine, because one trial have shown improvement in survival, and 2 trials have actually shown survival. But although there was difference in some toxicity, some
I think the hard thing in this
difference in
adjuvant
dose,
part
everything.
is using immunotherapy in an adjuvant setting in most solid tumors after CTRTs.
Yeah, that is also, we are not into any of the immunotherapy prospective phase 3 trials as of now.
Okay.
Yes, I agree with sir, because there was a keynote, another trial which is going on with pembrolizumab phase 3, because that study evaluating the role of after surgery followed by radiotherapy or after chemoradiation, is there a role for adjuvant immunotherapy? Okay.
All right, fine. So I think that's a nice introduction. So you have given us a nice overview of what is happening to us. And with this, I think may I request Dr. Manavalan, are we ready for the presentation now? Dr. Manavalan is our chief resident, so he is coordinating with all the residents for all the affairs. Dr. Manavalan, are you there?
Yes, sir. We are ready for the presentation.
Are you ready? So how is the team assembled? Are each of them watching through their own phones? Are we sitting in the boardroom assembling like that? Can we just have an idea so that the sir might understand very well the audience scenario and environment? Can you just briefly tell me how is it happening? Is everyone listening to their phones in an individual room?
Yes, sir. Everyone is listening individually, sir.
All right, fine. That will be nice. So, okay. So I think we can go ahead. So I will take this opportunity to introduce our famous oncologist, Dr. Cessal Thommachan. He is currently working as an additional professor in the Department of Radiation Oncology in Regional Cancer Center in Trivandrum. So he has reached a point now that he would not require any more introduction, because he has done plenty of YouTube lectures, online presentations over his work, and he has had a lot of expertise in handling head and neck cancers. He has trained himself to know about his educational background. He did his MBBS in Kottayam Medical College, and he did his diploma in medical radiation technology therapy, and MD in radiation oncology. Subsequently, he also finished his DNB with a gold medal. So that is an accolade to his performance. And he also has completed MRCP in medical oncology certification program in the year 2018, which many of the clinical oncologists are doing it to gather more relevance in the current scenario. So it is indeed a privilege. He has published a lot of articles. He has presented in so many forums as well. And there is a whole list which I might share in the group for everyone to understand. So to avoid wasting much time, I would go ahead and hand this over to Dr. Cessal Thommachan. Sir, over to you.
Okay, thank you, sir, for the kind introduction. And also I sincerely thank the Department of Radiation Oncology at RCC JIPMA, Pondicherry, for inviting for this program. And also I feel privileged, and also I sincerely thank my senior, Dr. Sharma, because she was the person who taught me the basics of oncology, okay? Because she was my senior, and when I was a first year student, I was posted, and she was a final year PG. Consecutively for 8 months, I was with her in gynec and breast clinic. So then she finished her MD. Okay, then I can move to the second year. So then, and I also have a close association with all the faculty members at JIPMA Pondicherry. Thank you very much for the kind introduction. So I will share my slides. Can you permit me to open my video? Yes, thank you. I will share my screen. Can you see my screen? Can you see my screen?
Yes, sir. Your screen is visible.
Yeah, thank you. So basically, this will be, we will do 2 days. Today we will discuss about the approach, manage the workup of carcinoma larynx, and also broad outline in the management. Tomorrow we will discuss about the evidence for the management and also the contouring guidelines. So how the carcinoma nasopharynx is different from other head and neck sites. You know that all the oral cavity, oropharynx, and hypopharyngeal tumors are staged size-wise, like less than 2 centimeter or equal to 2 centimeters is T1 disease, 2 to 4 is T2, and more than 4 centimeters T3. But that's not the case in two important things, one in larynx and other also in carcinoma and nasopharynx. Paranasal sinus tumors are also staged by subsite involvement. So the difference is for one, the larynx, other is nasopharynx, and third is the paranasal sinus tumor. How carcinoma larynx is different from other sites is one, the subclassification. So if you have a T1 disease in a hypopharynx oral cavity, it is less than or equal to 2 centimeters. And there is no T1A or T1B. Whereas in ocal cord, you have a T1A and T1B, because any tumor which is confined to one ocal cord, it is called T1A, provided there is no subglottic or supraglottic disease and it's a fully mobile cord. So that's one difference compared to other subsites. And it is not based on size criteria that I have already told you. And so majority of the patients, you can see that a majority of the glottic tumors present an early disease and they have a T1 or T2 disease at presentation, and they have a very good survival. That is important compared to the other subsites. And if you have oropharyngeal tumors, say like tonsil, soft palate, base of tongue, vallicula, there's not much difference in prognosis among subsites. But in larynx, the prognosis of a glottic tumor is good compared to a supraglottic tumor or a subglottic tumor. So prognosis among subsets are different in larynx. And if you look into the NCCN guidelines, you can see that there is a separate guideline for supraglottis, separate guideline for glottis, and also a subglottis. So it means subsite also there is separate treatment guidelines are there for in larynx. That's how it is different from other sites. Now, when a patient, most of these vocal cord patients present with hoarseness, okay, never think that the hoarseness means, so hoarseness means it is vocal, it is larynx alone. It can be from CA lung, it may be from a papillary carcinoma thyroid. We need to understand that we have to take a detailed history, and also we need to do a clinical examination properly to see whether a thyroid swelling is present. In the general examination, always you have to look for a clumping. If you're clumping with hoarseness, it may be CA lung. If you have a thyroid swelling with a hoarseness, it may be papillary carcinoma thyroid. And also the patient with a dysphagia with a whole, and patient is having hoarseness, it may be a C esophagus and patient is having a mediastinal nodes and the large lesion in the mediastinum that causing a nerve damage. Patient, so we need to think that it is not alone larynx. That is the important thing you need to look. And after this, most of this supraglottic tumors mainly present with a foreign body sensation. If it extends into piriforms, patient can have dysphagia, then cervical lymphadenopathy, and painful swallowing. This is how the patient present with in supraglottic tumors. So any of this hoarseness which is lasting more than 2 weeks, then you need to have an evaluation and to know whether it is a malignant process is there or not. So when you do any patient who is presenting to the clinic, first and foremost thing with a suspect larynx, whether the patient is having any airway compromise. That's the most important thing. The moment the patient comes to your OP, you have to look for whether the patient is having stridor. Okay, that's first. And what is the respiratory rate like? Then you have to look for whether the patient is having any lymph nodes in the neck, whether the laryngeal framework is normal, any widening of the laryngeal framework, then thyroid cartilage, whether the splaying of thyroid cartilage is present or not, then whether cartilage crepitus is, whether the laryngeal crepitus is present or not. Then after that, you do an IL examination, then you need to know the structures which you see in the IL. So this is the epiglottis. Okay, this is epiglottis here. This is the arytenoid. Okay, so something which connects epiglottis and arytenoid, it is called the aryepiglottic fold. They make things very simple. Epiglottis, arytenoid, aryepiglottic fold. This is false cord. Okay, false cord. And between the false cord and two vocal cord, that's a ventricle. Okay, so the parts of the supraglottis is one, epiglottis. Second is the arytenoid cartilage. Third is the aryepiglottic fold. Fourth is the false cord. And between the false cord and two vocal cord, that's a ventricle. So these are the 5 parts of supraglottis. Then on either side, then down you have this is a true vocal cord, right? This is a true vocal cord. On either side of the aryepiglottic fold and between this is on lateral to that, you have the thyroid cartilage. Then this area is called the piriform fossa. This is the piriform fossa on either side. Okay, so the medial boundary of the pyriform fossa is formed by the aryepiglottic fold. Medial boundary of the pyriform fossa is formed by the aryepiglottic fold. Okay, so this is the aryepiglottic fold. Now, when you have a patient with a patient of the symptoms, then you have to do an IL, then you have to look whether the lesion is, okay. Suppose if you have a lesion on this is a vocal cord lesion, this is a very whitish lesion, you can see that. Then you have to look for where is the lesion present. It is present on the entire vocal cord or the mid cord like this. What about the anterior 1/3, posterior 1/3, anterior commissure here, posterior commissure here. So that is how you have looked. Then you have to look for the mobility of the vocal cord. Lesion is extending in the supraglottic, any supraglottic or a subglottic extension is present. So this was a T1 disease. This patient had a impaired mobility. So it is called a T2 disease. So what is T1A? What is T1B? When both vocal cords are involved, that is T1B. When one vocal cord is involved, that is T1A. And the patient should not have any supraglottic or subglottic extension. And patient should have a fully mobile cord. Then only it is T1A. The mobility of the vocal cord is impaired, or when the lesion extends in supraglottis or in the subglottis, then that is called T2 disease. Okay, what is T2? Say impaired mobility, lesion is extending in the supraglottis or subglottis, it is T2. When the lesion is extending into the lesion is extending in the lingual surface of the epiglottis, or lesion is extending into vallicula, that is also T2. The lesion extends into pyriform fossa, then that's also T2. So that these are all constitute T2 disease in a laryngeal tumor. So most important thing, for any clinical or any oncology problem, most important thing is the patient should have we should have a proper physical examination. That's performance tests and nutritional status. Then you should proper clinical examination of the primary tumor and neck. This is the checklist for doing an endoscopic evaluation. One, you have to look where is the primary site. This I already mentioned. What is the nature of the growth? Extension to other subset of the larynx. The lesion is extending into the hypopharynx, or that's also you have to mention. The mobility of the vocal cord, whether anterior commissure is involved or not. The anterior commissure involvement will not change the staging of the disease, but if the patient is having anterior commissure involvement, there is high chance that the patient can have a T4 disease, and also the transglottic spread is more common in patients who have anterior commissure involvement. And when you have radiotherapy planning, it's also important that the patient is getting adequate dose if there is a patient is having anterior commissure involvement. Then mobility of the vocal cord. When you have a T1 vocal cord, then the fully mobile cord. In T2, it is impaired mobility. And you have to, when you have a T1 disease, it is our aim is to rule out that it is a T1 alone and it is not T2. So when the impaired mobility is there, then you have to rule out that the patient is not having T2. Then you have to rule out a paraglottic fat infiltration if the impaired mobility is there by a CT scan. Then extension to hypopharynx. Post-cricoid involvement from a supraglottic tumor, it is T3 disease. Airway evaluation. This is very important, especially in advanced disease. If you have a T3 disease and patient is having an airway compromise, then that may be the indication for starting the patient on induction chemotherapy. And another important thing is that any aspiration is present, function of the larynx. So these are the structures, these are the factors which you need to deal when you do a flexible endoscopy. So once you do a flexible endoscopy and a biopsy, then you will get an idea about the stage of the disease as well. Then you have to investigate the patient further to rule out one for the staging of the disease and also for prognostic factors and also for deciding the treatment. So the standard treatment investigation, the radiological investigation in carcinoma larynx is CT scan of the larynx, CT scan of the neck. CT is mandatory for all carcinoma larynx. Okay, because if you want to treat any patient, because that's even in early disease to decide a laser treatment or radiotherapy in patients. So we need to have a CT scan for all patients. X-ray test is good enough, but you can argue for CT of the thorax in certain situations, like if a patient is having a post-cricoid involvement, that's number one. A patient is having a subglottic extension is present. Patient is having level 3 or level 4 lymph nodes are present. And if clinically you have a clubbing is present, or if the patient is having any symptoms suggestive of any respiratory, other synchronous malignancy in the lung, then you have to do a CT thorax. Otherwise, you can get away with an X-ray chest. Then PET scan is not recommended as a baseline investigation for carcinoma larynx. Bone scan is not recommended. Okay, so if you look CT versus MR in neck, CT is having a better specificity compared to MR. MR is more sensitive because the main concern in larynx is whether the cartilages are involved, the thyroid cartilage, cricoid cartilage, arytenoid cartilage. All these cartilages are really a concern in the carcinoma larynx. So it is better appreciated by a CT scan. MR will show a high sensitive. So it may not be the true presentation of the tumor. So CT scan is the investigation of choice, and you have to do a thin slice CT scan. Okay, not like 0.5 centimeter. You should have a thin slice CT scan, especially if the patient is having an anti-recognition involvement. Now, the next part of my lecture will be to discuss. So we have discussed how to approach the problem. So we will do if the patient is having hoarseness, then you have to do an indirect laryngoscopy. Then you will get an idea. From there, you take the patient to a flexible endoscopy. Then you do a biopsy. From there, most of them 90 to 95% is squamous cell carcinoma. Then after that, you do a workup. Then the investigations to be done are one CT scan of the neck. Second is X-ray chest. CT thorax in patients who have teeth, in patients who have a post-cricoid subglottic extension level 3, level 4 lymph nodes. Then you have to do a CT scan of the thorax, and you have to do a baseline investigations, blood counts. And patients with advanced disease, always you should have a creatinine clearance test, then liver function test. And I forgot to mention, all patients should have a dental prophylaxis, except in a T1 ocal cord, where you plan only a limited oleum radiotherapy. Now, when we discuss about the next part is how to do an imaging and how to interpret that. Okay, so we need to understand that the larynx is divided into supraglottis, glottis, and subglottis. Okay, so what is supraglottis, glottis, and subglottis? Okay, so before that, we need to see certain the anatomical features. One is the hyoid bone. Okay, this is a hyoid bone. Okay, so this is a hyoid bone, and this is the thyroid cartilage. Okay, and the hyoid bone and the thyroid cartilage, there is a membrane which is connected. That is called the thyrohyoid membrane. The thyrohyoid membrane extends from the lower aspect of the hyoid bone to the superior border of the thyroid cartilage. So through this is a very loose area. From there, the tumors can extend, extralateral spread can occur without either involvement of the hyoid bone or thyroid cartilage. So the cartilage will be intact, but the patient can have an extralaryngeal spread. So these patients are generally treated by chemoradiation. I will discuss that. Okay, then you have the cricoid cartilage. So cricoid cartilage is more broad posteriorly compared to anteriorly. Okay. So on the superior aspect of the cricoid cartilage, then you have the two cartilages. That is called the arytenoid cartilage, and another is the corniculate cartilage. But you cannot see corniculate cartilage in CT scan. Okay. So this is the epiglottis. So this is the epiglottis. This is the epiglottis, which is having a free edge, and also. And this is attached to the thyroid cartilage. This is the thyroid cartilage, and it is attached to the thyroid cartilage. That is thyroepiglottic ligament. There is a ligament which connects the epiglottis to the thyroid cartilage in the anterior aspect. That is called the thyroepiglottic ligament. So this is the attachment. Okay. Then you have, this is the arytenoid cartilage, rest on the cricoid cartilage. So when you see 3 cartilages in a CT scan, that is the level of the glottis. Okay. One is the thyroid cartilage, second is the cricoid cartilage, and third is the arytenoid cartilage. If you see 3 cartilages in a CT scan, that is the level of the true vocal cord. So anything above that, that is called the supraglottic larynx. Anything below that, that is called the subglottis. Okay, I will show you the subglottis in CT scan also. So you have what are the parts here? The parts here, one is epiglottis here. This is the arytenoid cartilage, which you have seen. And then you have this is the aryepiglottic fold here, this arytenoid cartilage here. Then this is the epiglottis, the aryepiglottic fold. Okay. So this is the false cord. False cord is also part of the supraglottis. False cord, we will discuss that false cord. Between the true vocal cord and false cord, you have the ventricle. So these are the parts of the supraglottis. Then why you need to have an imaging in carcinoma larynx? One, it is for staging the disease. Second, you have the submucosal spread can occur, and also the extent of the disease, nodal evaluation. And also it is important for treatment decision, whether to go for chemoradiation, radiotherapy, surgery in early disease, or whether to go for chemoradiation or surgery followed by radiotherapy in advanced disease. Then it is very important for radiotherapy planning, because we know we all can do in CT scans. Then evaluation of the disease after treatment. So these are the goals of doing imaging. So I have already discussed CT is the investigation of choice. Although I have said MRI is a problem solving tool, sometimes the MRI can create a lot of issues too, okay, because of the high sensitivity. This I have discussed earlier. So then which are the situations where you will come across the decision regarding CT of the thorax? If the patient is having clubbing, bulky subglottic disease, post-cricoid disease, N3 disease, level 3, level 4 node, or respiratory symptoms. So we will see a normal CT scan here. So this is the base of the tongue. You have the base of tongue here. This is the area is the vallicula. So this is the area of vallicula. Then this is the lingual surface of the epiglottis. This is the epiglottis. Epiglottis is part of the supraglottic larynx. So this part, this is the hyoid bone. And this is, you draw a line from here. This is the suprahyoid part of the epiglottis. This is the free edge of the epiglottis. Okay, it has two portions. One is the mobile portion, another is a fixed portion. Okay, then this is a hyoid bone and this is a thyroid cartilage. Okay, so this space is called the pre-epiglottic space that I will discuss later. This is the pre-epiglottic space. All the spaces in CT scan in head and neck is black. It's a hypodense because of the fat. Okay, in MR it is hyperdense. Okay, so this is a hypodense area. That's a pre-epiglottic space. Okay, there is a ligament which connects the epiglottis and the hyoid. This is called the hyoepiglottic ligament. Actually, we cannot see that ligament. That forms the superior border of the pre-epiglottic space. Okay, hyoid and epiglottis, hyoepiglottic ligament. This is at the level of the floor of the mouth. Okay, so why you said floor of mouth? You can see the mylohyoid muscle here. So that forms the floor of mouth. You can see epiglottis at that level itself. Okay, so see this you can see at the level of the floor of mouth. So you are seeing epiglottis at the level of the oral cavity itself. It does not mean that it is part of the oral cavity. It is part of the larynx. Now lateral to that, this area, this is a hyoid bone, and this area, this space, this ligament, that's called the medioglossopeglottic. This is the median glossoepiglottic ligament. So okay, sorry, median glossoepiglottic fold. I'm sorry. This is called lateral. This is called the pharyngoepiglottic fold. This is a pharyngoepiglottic fold. Then this is epiglottis. On either side of this median glossoepiglottic fold, you have the vallicula. So this is a vallicula. Vallicula is not part of the larynx. This is part of the oropharynx. In the inferior most portion of the vallicula, that's the area where you come across the epiglottis. You see that this space is called the pharyngoepiglottic fold. And this forms the inferior boundary of the oropharynx. This is seen somewhere here. So that is the hyoid here, the epiglottis. When you see axial cut, you will see something like this. That is the vallicula. So this is the vallicula here in the sagittal view. Okay. Now this is the coronal view. You can see that this is the epiglottis here. This is a vallicula, and you can see a small area here. This is the paraglottic fat. Okay, we will discuss that later. This is a paraglottic fat here. This is a hyoid bone here. This is the thyroid cartilage. Now, if you have a tumor in the epiglottis, how the tumor spread? Okay, why you need to know how the tumor spreads? That's how you look in CT scan. That's number one. Number two, it is also important for contouring, because you have to look specifically where this area is important. Suppose if you have a tumor in the epiglottis, how the tumor can spread? Tumor can spread from here, epiglottis and arachnoid cartilage. So the tumor can extend to aryepiglottic fold here. The tumor can extend to pre-epiglottic space here. It can extend into the superiorly into the vallicula here, vallicula, and also it can go down into the level of the, it can go down. So it can go into area epiglottic fold from here. It can extend the pre-epiglottic space. It can extend into the vallicula. Okay, that's how the tumor spread from a tumor from epiglottis. Okay, so now if you have a tumor here, okay, how it can spread? It can spread into the arachnoid by the area epiglottic fold here. It can go down into the it is into the false cord that we will discuss later. And also it can go into the vallicula. It can go into the vallicula from there. So that's how a tumor in the epiglottic spread. Okay, this is how you see in CT scan. And CT scan, you can see that. You can see in the CT scan here. This is the you can see this is the hyoid bone here, and you have the, this is the epiglottis. Okay, epiglottis. This is the area epiglottic fold. This is a normal area epiglottic fold. Area epiglottic fold extends from the this is from the epiglottis to the arachnoid cartilage. We will trace that down into the arachnoid cartilage. So here is the epiglottis. This is area epiglottic fold. Posterior to the area epiglottic fold, you have, this is the pyriform fossa. Here it is a pyriform fossa. So this is the pyriform fossa on right side. This is a pyriform fossa on left side. This is a posterior pharyngeal wall. Okay. So this space, this hypodense area is called the pre-epiglottic space. This is a pre-epiglottic space. Pre-epiglottic space is continuing laterally as the paraglottic fat. This is a paraglottic fat. And this is the normal pyriform fossa on right side. Left side, it is obliterated. Okay. So I said in the beginning, the medial boundary of the pyriform fossa is formed by the lateral surface of the area epiglottic fold. So this is the medial boundary of the pyriform fossa is formed by the lateral boundary of the area epiglottic fold. This is the posterior pharyngeal wall. Okay, so this is at the level of the hyoid bone. Okay, now next is the area epiglottic fold. Okay, so you have a tumor. If you have a tumor in the area epiglottic fold, how it can spread? It can spread into the posterior pharyngeal wall here. Laterally, it can spread into the pyriform fossa here. And anteriorly, it can spread into the paraglottic fat here. And it can extend into the pre-epiglottic space. And it can also go down. Okay, that's how a tumor in the area epiglottic tumor spread. Okay, so now what we have seen, the epiglottis and the area epiglottic fold. And suppose if there is an abnormality, what all things, why you should look for and how you should look for. One, always you look for an asymmetric soft tissue prominence or thickening. Second, any contrast enhancement. Look for any bulky mass. Now always you should look for the obliteration of normal fat planes and species. So that's how you have to look in larynx. Okay, so we'll take one by one. So you have this is the normal pre-epiglottic space. This is the epiglottis, pre-epiglottic space. You have the area epiglottic fold here. Can you make out that? And this is the pyriform fossa on the left side. But on left side, on right side, you can see a lesion in the area epiglottic fold here. It is extending into the pyriform fossa, obliteration of the right pyriform fossa. It may be a pedunculated lesion. Posterior pharyngeal wall seems to be okay. It is not involved. Minimal extension into the paraglottic fat. You can see the left side, the paraglottic fat can be clearly made out, but you cannot clearly made out. The obliteration of the right paraglottic fat is there. Because of this, lesion in the area epiglottic fold is extending into the paraglottic fat here. It becomes a T3 disease. Okay. Now you can see a lesion is at the level of the, again, I have told you, this is at the level of the floor of mouth. You can see that at tongue and floor of mouth, you can see a lesion there. So this is a lesion in the epiglottis. We have a tumor in the epiglottis. Okay, you have the lesion in the epiglottis here. And the lesion in the epiglottis, you can see again the lesion, bulky lesion in the epiglottis and also in the area epiglottic fold. Left side, it is normal. And so this may be a T1 because if the lesion is confined to the area epiglottic fold alone, it becomes a T1 disease, even if the tumor is very bulky. But if it is involving the pyriform fossa, it becomes T2. If you have a paraglottic fat, it becomes T3. A pre-epiglottic space, it can be T3. Okay. So this is a bulky disease involving the epiglottis and area epiglottic fold on the right side. Next, how you look that lesion in the sagittal view, you can see a lesion here. This is involving the lingual surface of the epiglottis. This is a vallicula. So if you see it is a primary in the vallicula and it is extending into the lingual surface of the epiglottis, then that becomes a T3 disease. But if the lesion is arising from the epiglottis and is extending into the vallicula, then that becomes a T2. But whereas a lesion in the vallicula, it is extending in lingual surface of the epiglottis, it becomes T3. Okay. Now coming to the thyroid cartilage. Thyroid cartilage has a superior thyroid tubercle here. It is having an outer surface, it has an inner surface. Then you have an oblique line, you have an inferior thyroid tubercle there. And then the thyroid, how you look for the CT scan. And then before that, then you will look in the posterior surface. You can see that this is the arachnoid cartilage. So I will take the thyroid cartilage and arachnoid cartilage together. And arachnoid cartilage has a base which rests on the cricoid cartilage. And then you have an apex which gives attachment to the corniculate cartilage. So this is a pyramid-shaped lesion. It's a pyramid-shaped cartilage with an apex and a base. Okay, in the arachnoid cartilage, you need to understand it has an apex and there is a depression for the attachment of the vestibular ligament, which is called the false cord. That we will discuss. And also there is a depression for the attachment of the ocalis muscle. That's at the level of the true ocal cord. Okay, so this is at the level of the that's at the level of the supraglottis, and this is at the level of the true ocal cord. Okay, again I will discuss. Then you will be more. So now we'll come to. So we discussed epiglottis, aryepiglottic fold. Now we're coming to the third part of the supraglottis. That's called the false cord. False cord is the inferior most reflection of the aryepiglottic fold. It's also called vestibular fold. It is also called false cord. It's also called vestibular ligament. All are the same. It is called the false cord. Okay. Now you need to understand that how it is attached. So this is a false cord. False cord is attached at the in front. It is attached at the angle of the thyroid cartilage. This is at the level of the angle of the thyroid cartilage, immediately below the attachment of the epiglottis. Okay. So immediately below the attachment, this is the attachment of the epiglottis. That is by a ligament called thyroepiglottic ligament. Okay. So just below that, then you have a ligament which is extending. That's called the false cord. False cord, it is extending anteriorly at the angle of the thyroid cartilage, immediately below the attachment of the epiglottis. Posteriorly, it is at the level of the anterolateral surface of the arachnoid cartilage. So that is a false cord. Now, how you look for the false cord? So false cord, you look for the arachnoid cartilage because it is extending into the arachnoid cartilage. Okay. So if you have a lesion in the false cord, it can extend into the paraglottic fat. From there, it can go into the inner aspect of the thyroid cartilage. It can go in posteriorly. It can also extend into the pre-epiglottic space. So this is a normal thing. So this is a pre-epiglottic space. You have the paraglottic fat here. It's a normal paraglottic fat. This is a false cord. From there, a lesion can extend to, this is the thyroid cartilage. Okay, this is the thyroid cartilage. This is arachnoid cartilage. And if you have a tumor here, it can spread posteriorly. It can cause widening of the thyroid-arachnoid gap. This is the thyroid. This is the arachnoid. Can have a thyroid-arachnoid gap can be widened. It can extend into posteriorly in the post-cricoid. So that's one of the area way by which lesion in the supraglottis becomes extending into behind the cricoid. If so, then it becomes a T3 disease. Okay, involvement of a supraglottic lesion into the post-cricoid, it is a T3 disease. Now, for another concept is that's called the false cord. The ventricle. Okay, so you need to understand that. Okay, so this is the structures. What are the structures here? The structures here, this is epiglottis, this is a false cord, this is a ventricle, and this is a true ocal cord. So between the true ocal cord and false cord, you have the ventricle. Okay, this is a ventricle. It can be clearly seen usually only in the coronal view. Okay, coronal view is useful in certain things. One, to know ventricle is involved. That's number one. Two, early paraglottic fat infiltration. That I will discuss. And third, to know where a subglottic extension is present through a soft tissue. These are the areas where you will benefit from a you look for a involvement of the in the coronal view. So we have seen epiglottis, epiglottic fold, false cord, ventricle, then also the arytenoid, thyroid cartilage. Now we are coming to the true vocal cord, at the level of the true vocal cord. At the level of the true vocal cord, so I said in the beginning that when you see three cartilages, so this is the thyroid cartilage, this is the arytenoid cartilage, this is the cricoid cartilage. If you see three cartilages together, then we are at the level of the true vocal cord. So at the level of the true vocal cord, you have the, what are the structures there? Vocalis muscle is there, and this is the, then you have the apex of the pyriform sinus. This is very important. So apex of the pyriform sinus is seen at the level of the true vocal cord. Okay, these are the structures which you see at the level of the true vocal cord. Anterior commissure, posterior commissure, we will discuss that. Anterior, so true vocal cord, anterior commissure, posterior commissure, apex of the pyriform sinus. These are structures you have to look in a CT scan. Okay, we will take one by one. Okay, the anterior commissure. So first you ensure that this anterior commissure is at the level of the meeting of the two vocal cords. That's anterior commissure. And this is the arytenoid cartilage, and this is the cricoid cartilage. So if you see cricoid cartilage, arytenoid cartilage, and true vocal cord, sorry, thyroid cartilage, you are at the level of the true vocal cord. And this is the apex of the pyriform sinus. So you see on either side, you can see hypodense area. This is the apex of the pyriform sinus. Okay. So now what is the anterior commissure? Anterior commissure is the meeting point, and the posterior commissure is nothing but the arytenoid cartilage. You identify arytenoid cartilage on both sides. Okay, I will show you. So this arytenoid cartilage on either side, the area between the two arytenoid cartilage, that is called interarytenoid area, the posterior aspect, that is nothing but the posterior commissure. Okay. So this is the posterior commissure. So that is the interarytenoid area. Why you need to know all this? If it's a T1 disease, okay, if you have a lesion in the anterior commissure or in the posterior commissure, generally they are not treated with surgery. They are treated with radiotherapy in early disease. Okay, supraglottic or subglottic extension, again, these patients are treated by radiotherapy and not by laser treatment. Okay. Now you have a C lesion in the, you can see, so which level? It is a little down. Okay, it is, you are not seeing the arytenoid cartilage. It is little down. This is a cricoid cartilage. I told you that post-cricoid, the cricoid is more broad posteriorly compared to anteriorly. So you can see a lesion there, which is involving both vocal cords. You can see that lesion is crossing to the opposite side. Anterior commissure is also involved. And also you are seeing a subglottic extension is present. How you look for a subglottic extension? Usually, you should not see any soft tissue. You can, on the right side, you are not seeing any soft tissue inside the cricoid cartilage. If you see any soft tissue in the cricoid cartilage, then you have to think that this lesion is extending into the subglottic area. So this patient is having a subglottic extension. And you can see that compared to this side. Okay, so you can see that the lesion is extending on the left side into the cricoid. So if you have a lesion in the glottis, how the tumor spread? Can spread again into this laterally in the glottic fat, paraglottic fat here, then inner cortex, then the destruction of thyroid cartilage, extralateral spread. Anteriorly, it can spread in anterior commissure, posteriorly into the posterior commissure, then it can spread between the interthyroarytenoid gap and then go posteriorly. And also it can go downwards into the subglottic area. Posteriorly, superiorly can go in the supraglottic larynx, and from the paraglottic fat, it can also enter into the pre-epiglottic space. That's how a tumor in the glottis spread. Okay, then we will discuss two, three spaces. Okay, it's almost 40 minutes now. Okay, now this is the pre-epiglottic space here. It is bounded superiorly by the thyroepiglottic ligament. So, sorry, hyoepiglottic ligament. Sorry, it's a hyoid cartilage, epiglottis, hyoepiglottic ligament. Then medially by the thyrohyoid membrane, posteriorly by the epiglottis here, and inferiorly by, this is the area. You can see that this is the area where the epiglottis is getting attached to the thyroid cartilage. That is called the thyroepiglottic ligament. So this forms the inferior boundary of the pre-epiglottic space. Okay, now when you see CT scan, you can see this is the pre-epiglottic space here. And this I already discussed, this is a pre-epiglottic space. Why pre-epiglottic space is involvement? Because it's rich in lymphatics. And once the tumor invades the pre-epiglottic space, there is a high chance that the patient can have a heavy nodal disease. Okay. Here you can see a lesion in the you can see a lesion in the epiglottis extending into the pre-epiglottic space. The pre-epiglottic space is obliterated, same here. And this you can see involves the aryepiglottic fold on both sides, extending into this is the paraglottic fat that we will see in a minute. And on the left side, the paraglottic fat is obliterated. Right side, you can see the paraglottic fat, but the pre-epiglottic space is obliterated, but you cannot make out any gross cartilage destruction here. Again, the same here, it is extending into the pre-epiglottic space. Now we will see a pre-epiglottic space involvement always may not be from lesion in the larynx. It can also extend from, you can see a base of tongue lesion. You can see a lesion in the base of tongue. It causes obliteration of the pre-epiglottic space. So once the patient is having oropharynx extending into the pre-epiglottic space, it becomes T4A. Whereas if it goes into the base of tongue, it becomes T2, provided the extrinsic muscles of the tongue is free. So oropharynx extending into larynx is T4A, and it vice versa, it is T2. Yes. Now coming to the paraglottic fat, laterally, the pre-epiglottic space continuing as a paraglottic fat. Again, it is a hypodense area. You can see this is a paraglottic fat. I will show you a few situations where the paraglottic fat is obliterated. So on this card, you can see this CT scan. On which level it is? Okay. So you are not seeing any cricoid cartilage here. So you are not seeing any arachnoid cartilage here. So it is at the level of above the false cord. If you see a false cord, then it is at the level of the arachnoid cartilage. You are not seeing any arachnoid cartilage. So above that, it's a lesion in the epiglottis and aryepiglottic fold on the right side. This is a lesion which causes obliteration of the paraglottic fat and just up to the pre-epiglottic space. So it's a T3 disease. Here also you can see on the left side, you can see the paraglottic fat, but on right side, the paraglottic fat is obliterated here. It's extending into the pre-epiglottic space. Lesion is involving the aryepiglottic fold here, and the extension into the posterior pharyngeal wall. Left side, you can see the again lesion in the aryepiglottic fold, it's causing obliteration of the paraglottis. So it's again, it is a T3 disease. Now, what are things where lesion makes T3? One is hemilarynx fixity. Second is pre-epiglottic space, we have seen. Third is a paraglottic fat. These three things can make a larynx T3. And also I have mentioned post-cricoid involvement from a supraglottic tumor. That's also T3. The last T3 is inner cortex involvement. In the inner cortex involvement, inner cortex tumors are generally treated by chemoradiation. It's not by surgery. You can see the inner cortex. So in these patients, you should have a proper interaction with your radiologist because there can be a minimal extralaryngeal spread through cartilage. If it's not thin slice, then you may miss that. Okay, it's very important. Here you can see the lesion is also involving the subglottis. Inner cortex involvement is there, subglottis. You can see that this side, cricoid cartilage, you are not seeing any soft tissue. You can see an enhancing lesion there. So this is a, you can see that. Okay, so here, this is subglottic extension. Inner cortex is involved. Inner cortex is involved. So it's a T3 disease. Again, you can see that another situation where you come across inner cortex, that's also T3 disease. So when you discuss the T3 disease, generally they are treated by chemoradiation. In T1 or T2 disease, generally they are treated by radiotherapy or surgery. It gives equal results. But when you treat a supraglottic T1 or a T2, you have to treat the neck also. But T1 and T2 vocal cord, there is no need to treat the neck. But in T3, standard treatment is to go for chemoradiation. 2 endoscopic findings and 3 CT scan findings. Hemilarynx fixity, you can make out in the OP itself. Post-cricoid, you can make out from flexible endoscopy. But paraglottic fat involvement, pre-epiglottic space involvement, inner cortex involvement, they can be made out only in a CT scan. They can be made out only in a CT scan. That's why you need to know that. And this patient should have a CT scan. Without CT scan, never consider chemoradiation for laryngeal tumors. It is very inevitable because it is we will miss many things. But it may be a T3 disease, but there may be an extralaryngeal spread that it may be a T4 disease. Ideally, the T4 disease should undergo a surgery. Okay. Here, this is a subglottic disease. You can see that soft tissue here. And here you can see an extralaryngeal spread. And this can occur in two situations. One, through thyrohyoid membrane that I told you in the beginning. Second is cricothyroid membrane. There is another membrane called cricoid cartilage, thyroid cartilage. That's called the cricothyroid membrane. You can see that. So you can see minimal the extralaryngeal spread. It may be T4A, but if the cartilage is intact, then the patient can be treated with T4A. Then again, this is at the level of the true vocal cord, because you are seeing the thyroid cartilage, cricoid cartilage, arachnoid cartilage. I'm showing different pictures, then you will be more thorough and you will be able to read the CT scan by yourself. You can see the anterior commissions involved. Here you can see a lesion involving the left entire vocal cord. You can see anterior commissions involved. The posterior commission is also involved. And compared to C, you can see that there's a thyroid. This is the thyroid cartilage. This arachnoid, thyroid gap is widened compared to this side. So this is making a way to extralaryngeal spread. So you can see thyroid, there's arachnoid, thyroid-arachnoid gap is widened, the lesion is extending posteriorly, extralaryngeal spread. That becomes a T4 disease. Anterior commission involvement. Okay. Sometimes another important thing you have to look into very advanced disease is airway, because you can see very extensive disease involving entire supraglottic larynx and minimal sleep. You can see minimal sleep there. So this patient should have, if the cartilage is intact, but splaying of thyroid cartilage can be seen when you palpate. You can see that a hard lesion on one side of the thyroid. So sometimes it may mimic a node. No, it is not hard node. No, it is an extralaryngeal spread here, or splaying of thyroid cartilage. So this is a T4A disease, and this is actually a minimal extralaryngeal spread. Here also it's a T4A, but cartilage is intact. Then you can consider the patient for chemoradiation, but never consider chemoradiation upfront. This can lead on to tracheostomy. But this is a situation where airway compromise, T3 disease, you may have to go for induction chemotherapy. You take care of the airway, then you consider the patient for radiation. Now another concept is transglottic carcinoma. Transglottic carcinoma is nothing but any tumor laryngeal encroaching both the glottis and supraglottis, with or without involvement of subglottis, and where the site of origin is unclear, that is termed as transglottic. So you have a lesion, it's encroaching both and glottis and subglottis. Subglottic extension may not be present or not, but then it involves the supraglottis and glottis, but we do not know where is the primary site of origin. Transglottic tumor, it's only T2, it's not T3. So transglottic tumor, it becomes a paraglottic fat infiltration, it becomes T3. Otherwise, there is no, it's only T2. I will take one CT scan where I'm trying to summarize the whole thing, what I have told you so far. So you can see a lesion. So this is the arachnoid cartilage. So which level? It's supraglottis. Then which level? Again, to be more specific, at the level of the false cord, because you are seeing arachnoid cartilage. Okay, you see a true vocal cord, then it is at the level of the true vocal cord. So this is, you are seeing thyroid cartilage, cricoid cartilage, arachnoid cartilage. You see true vocal cord. So you see only arachnoid and thyroid, it is at the level of the false cord. You can see a lesion in the right, the lesion there. It is causing obliteration of the paraglottic fat. And also at the level of the true vocal cord, you can see anterior commission is involved. Posterior commission is also involved. You can see erosions of the anterior aspect of the cricoid cartilage. You can see that. And also you have to see that there is an inner cortex is involved. The thyroid cartilage, inner cortex is involved. And slight the extralaryngeal spread, you can see that from the cricoid and thyroid cartilage. And also there is a subglottic extension is present. You can make out subglottic extension here. It's normal. Here you can see subglottic extension, extralaryngeal spread. And also subglottic extension is present here in the coronal view. You can see that. So in this side, you are not seeing any soft tissue. But if you see any soft tissue at the level of the cricoid cartilage in the coronal view, then you have to think that this patient is having a subglottic extension. Now, extralaryngeal spread can be with or without cartilage destruction. I told you thyroid cartilage, a thyrohyoid membrane. And how you look for is that if the boundary is very sharp and it is not irregular, then you can make out that there is There is within the thyroid membrane. But then sometimes you have to see that thyroid membrane is pierced and you can see an extralaryngeal spread here. And also the lesion is involving the paraglottic fat. Lesion is causing the posterior pharyngeal wall is also involved. You have to make out whether the prevertebral fascia is intact or not. What about very close to the vessels here? And these are real concerns in this patient, whether the patient is having any nodes here. What about the thyroid cartilage? Okay. Now coming to patients with a thyroid cartilage destruction, if you have a lesion with thyroid cartilage, you can see very thyroid cartilage destroyed. You can see a lesion extralaryngeal through and through thyroid cartilage. And this patient should undergo a standard surgical treatment followed by post-op radiation. You can see a lesion there. And this patient, actually, I've seen this patient today in OP, 81-year-old man, presented with thyroid cartilage destruction. And it was actually, initially, it is endoscopically, it is a very small lesion. So that's why the performance was very good. That's why I've asked for a CT scan. But here you can see extralaryngeal spread through and through cartilage. And also widening of the thyroarachnoid gap is widened. Extension into the level of the posterior commissure, anterior commissure is involved. And this patient, it's 81-year-old man, decided for palliative treatment. Then same thing, okay. So you can see that extralaryngeal spread here. This is a bone window. So this may be a situation in young patients, okay, patient with good performance status, 0 or 1 or less than 70 years. This patient should undergo a total laryngectomy followed by post-operative radiotherapy. It's a planned treatment and never consider chemoradiation for this group of patients. Standard treatment is to consider total laryngectomy, bilateral neck dissection, anterolateral neck dissection, level 2, 3, and 4 clearance, followed by a planned post-operative treatment. If any margin is positive or extracapsular extension of the node, then you have to consider post-op chemoradiation. It's a planned treatment. So whenever you send any patient for laryngectomy, always you have to understand that this patient should have enough reserve to undergo the planned treatment, that is surgery followed by post-operative treatment. Now, T4A disease, it can be extralaryngeal extension. Any extralaryngeal extension is T4A. If it is cartilage destruction is present, the patient should undergo surgery. Trachea plus trachea infiltration is also T4A. Generally, they are treated by chemoradiation. Thyroid gland involvement, if the cartilage destruction is present, then you have to do a thyroidectomy as well. Esophagus extension is also T4A. It's usually treated by chemoradiation if the cartilage is intact. Extrinsic muscles of the tongue is involved. Generally, they are treated by chemoradiation. That's also T4A. So if you have inner cortex involvement, you straight away consider the patient for chemoradiation. If it is penetration, then you should have a proper discussion with the radiologist. Ensure that there is no extralaryngeal spread, then you can consider chemoradiation or surgery. In this situation, you have to individualize. If it's a through and through cartilage, then it should be surgery followed by post-op radiation. And through and through cartilage involvement, this may be the absolute, okay, this may be the absolute upfront indication for doing surgery. So you have, in this situation, never consider chemoradiation. You have to consider the patient for a total laryngectomy followed by post-operative. Now coming to the very advanced disease, T4B disease. In T4B disease or N3B disease, in all other situations, treatment should be individualized. And what is T4B? A prevertebral fascia involvement. You cannot make out any plane there. Encasement of the carotid artery like this. Encasement of the carotid artery, or the patient is having a mediastinal involvement. All these are T4B disease, and generally we have to consider. Generally, they are considered for a, in highly selected patient, you can consider them for a radical approach. Otherwise, you have to consider them for a palliation. If this is a very advanced disease, you can see that there is, you can see that lesion in the paraglottic fat, prevertebral fascia involvement. This patient has a pyriform sinus involvement. Nutrition will be compromised in this patient, and engagement of carotid artery. So this patient generally go for palliation. In highly selected patient, you go for a radical approach. The cartilage is intact, then you can go for chemoradiation. It is considered for relatively young patient, good performance status, patient with good social support, highly motivated patient, low volume disease. Generally, they are treated by chemoradiation. But if the cartilage is destroyed and prevertebral fascia is involved and you want to consider them for a radical approach, then you should give induction chemotherapy. And if there is a response after 2 to 3 cycles of chemotherapy, prevertebral fascia is free, then you consider the patient for total laryngectomy, followed by post-operative failure. If the patient then notes any node in head and neck squamous cell carcinoma is a stage 3 disease, a single node ipsilateral, and there should not be any features of extracapsular extension, and the node size should be less than or equal to 3 centimeters. That is N1. Any N1, it is a stage 3 disease. If 2 nodes, so like you can see that multiple nodes, then it becomes N2B, multiple nodes, none more than 6 centimeters on one side, and it is no features of extracapsular extension, then it becomes N2B. And any node, it is N2 is a stage 4 disease. The bilateral nodes, it becomes an N2C, it becomes a stage 4 disease. Whenever a patient is having any features of any extracapsular extension, then it becomes N3B. This or if you can see that compared to this side, you can see that extracapsular extension is present, then this becomes an N3B, it becomes a stage 4B disease. N3A is any node more than 6 centimeters and no features of extracapsular extension. Now, those who join late, I'm summarizing. So this is the hyoid bone. This is the thyroid cartilage. This is the thyroid cartilage. You can see arachnoid cartilage here. This is a cricoid cartilage. Okay, this is a cricoid cartilage. Okay, so these are the bony landmarks here. You have the aryepiglottic fold here, epiglottis here, the pre-epiglottic space here, paraglottic fat here. This is a pyriform fossa. This is the aryepiglottic fold, arachnoid cartilage. So it is at the level of the false cord, again at the level of the false cord, at the level of the true vocal cord, because you can see thyroid cartilage, you can see the cricoid cartilage, you can see the arachnoid cartilage. So it's a level of the true vocal cord. Now, if you see any soft tissue, then this is at the level of the subglottis. Okay. Now, the checklist for imaging, one, you have to look for where is the tumor, where is the supraglottis, glottis, where the lesion is extending into the subsides of the supraglottis, etc. Tumor oleum size, it can only be clearly seen in a CT scan, not in an endoscopy. Pre-epiglottic space, it is T3. Paraglottic space is T3. Post-cricoid is T3. Extension to other subside becomes T2. Anterior commission will not change the staging. Where the cartilage involvement, thyroid gland T4A. You need to know the superior and inferior extent. Prevertebral fascia involvement T4B. Inoperable disease. Encasement of the carotid artery. Then that's also T4B disease. Extralaryngeal spread T4A. It can be with cartilage destruction or without cartilage destruction. If it is with cartilage destruction, it is surgery followed by radiation. If it is without cartilage destruction and no functional issues, standard chemo radiation. Also, you need to know whether it is N1, N2, or N3 disease, or N0. Thank you very much for your patient listening. Okay, I think that's the last slide. Okay, just see. Yes, thank you very much. Okay. Yes, I'm happy to take few questions.
Thank you, Dr. Cessal. I would request our Chief Resident to coordinate this question session so that there is no overlapping of audios and from multiple people. Dr. Manavalan, please handle the question and answer session.
Yes, sir. Thank you, sir. Thank you, sir, for your wonderful presentation. Sir, we have a few questions from the participants.
Yeah, can I take that? Can I take?
Yes, sir.
Okay. So if a patient is with a cartilage erosion, why not CT-RT in cartilage erosion? If a patient is having cartilage erosion, that patient should be considered for chemoradiation. It is not surgery. But once the patient is having a through and through cartilage, extralaryngeal spread, then generally these patients are not considered for chemoradiation because they are treated by chemoradiation. They are treated by surgery followed by post-op radiation. Why the patient, why surgery could not be done in thyroid cartilage invasion rather than, why surgery could not be done in thyroid cartilage invasion rather than CTR? Okay, so I will make very clear. Why the patient with a thyroid cartilage destruction should undergo surgery? Because if you look into the VIA trial, where they looked T4 patients were also included in the trial. They've given induction chemo. I will discuss that when we discuss the management, the evidence tomorrow. But when the patients received induction chemotherapy and they were offered an organ preservation approach based on the response, if the patient who achieved 50% regression were offered radiotherapy, what they found out at follow-up was that those patients had T4 disease and offered a organ preservation approach, this rate, salvage laryngectomy rates were very high. When they compare T3 versus T4, T3 means is inner cortex. T3, the salvage rates were only 28%, but it was 56% in patients who received in T4 disease were offered chemoradiation. That's one of the concerns where still in T4 with cartilage destruction, we generally offer the patient a primary surgery followed by postoperative radiotherapy. That's one, I think that makes sense. Then how does cricoid erosion affect management? If the patient is having a cricoid erosion, you should not change the management. You can take the patient for chemoradiation. Sir, in T3, T4 disease, what should be the contraindication for surgery? What should be the contraindication for surgery? Is involvement of apex superior contraindication for surgery? Okay, that's a very good question. In T3, T4 disease, always in stage 3 and stage 4 disease, always you try to preserve the larynx. Okay, the standard treatment, if no, two things: one, no extralaryngeal through and through cartilage, and no dysfunction by in terms of aspiration. All patients should be offered a radical chemoradiation. If a patient is having through and through cartilage, then that patient should undergo surgery. Whether the patient should undergo a total laryngectomy or you can get it with a near total laryngectomy, that's a new concept. That's a good concept where you can, if the one cricoarytenoid joint can be preserved, like its nerve supply, all these muscles, and it is functioning, and then you can do and it is a well lateralized disease on one side, then you can do a near total laryngectomy. And the patient should undergo a neck dissection for all patients. In a T4, a pure glottic disease, chance of lymph node involvement is around 20%, but still the patient should undergo a neck dissection. That's very high in supraglottic larynx with T3 or T4 disease. Is there a role for negative neck radiation T1 and T2 and zero larynx patients? That's again a very good question. In T1 and T2 vocal cord, chance of lymph node involvement is very low. In that situation, you need not treat the lymph nodes, provided there is no subglottic extension, no supraglottic extension, fully mobile cord, or even in the impaired mobility where CT scan shows there is no paraglottic factor. In that situation, you can get with T1 and T2 disease in pure glottic tumors. Whereas in supraglottis, that's very different. If you look into the series, you can see that the chance of lymph node involvement varies from 27 to 42% in T2 disease. In supraglottis, and say midline disease, always you have to treat the neck. If you are treating with radiotherapy, generally they are treated by radiotherapy. T1 and T2 supraglottic larynx is treated by radiotherapy. Always you have to treat the bilateral neck, level 2, 1, 3, and 4, 2, 3, and 4. If you're using IMRT, then you have to treat bilateral 50 gray equivalent dose. Okay. And now the risk of aspiration post CTRT with NAD vary with stage or initial disease. Okay, there are various factors which determine the aspiration or the dysfunction of the larynx post chemoradiation. The oleum irradiated, what is the status, function status before chemoradiation, and the oleum of the disease, then the dose per fraction, where the chemo was given along with radiation. All these factors contribute whether the patient can develop potentially the patient can develop a dysfunction after chemoradiation. And this is also a real concern. If a patient is aspirating after chemoradiation, the patient may be in remission, but the patient is having a dysfunctional larynx. Then you may have to consider the patient for a salvage laryngectomy. Otherwise, the patient will have aspiration pneumonia, and we may lose the patient due to aspiration. So it's a real concern. It's also a real concern. Yes, I have taken. I have taken all the questions. Okay, tomorrow we will discuss the evidence for the management. Basically, T1, T2 disease, the evidence is mainly retrospective. In advanced disease, how the chemoradiation has evolved. Then we will discuss the nodal oleum delineation. Then I will also share our own results very recently published chemoradiation in advanced laryngeal cancer. Any other questions? Shall we wind up then? Okay. Yes.
Thank you, sir. We have covered all the questions for now. So can we wind up for today, sir? And for tomorrow, we can join with the
if there is
same.
no more questions, I think we can wind up. Okay. Thank you again very much for the patient listening. I'll be very happy to interact more. Yes. Yes. Shall we wind up then? Okay.
Yeah, Dr. Cessal, thank you very much. We'll meet you tomorrow then.
Yeah.
Thank you.
Sure.
Okay.
Thank you.
Have a nice day.